Hello everyone, my name is Bob Nelson and today I'll be presenting a patient safety proposal and asking leadership to approve a targeted pilot to implement Barcode Medication Administration or BCMA for our allergy injection clinic. I'll briefly describe a recent safety event, show why BCMA prevents that error, summarize the evidence, and outline a practical pilot plan, and then request approval to begin. Recently, a medical assistant prepared and drew an allergy serum syringe before the patient was identified at the bedside, then administered the injection without performing the required bedside verification. And this broke our updated clinic policy and created a risk of wrong patient or wrong serum administration and even potentially anaphylaxis. The MA unfortunately was ultimately terminated, but this event provides a unique catalyst for change by highlighting a flawed system that a single person corrective action alone will not fully resolve. Our policy, which relies only on human memory and is easily bypassed, set that MA up to fail, proving it is our system that needs corrective action. My proposal is the immediate implementation of Barcode Medication Administration or BCMA, specifically for all allergy injections in our medical offices. BCMA provides a proven solution to this exact problem. BCMA is a point-of-care engineering control, and the goal is simple: 0 pre-drawn unverified syringes. When a nurse or MA scans the patient's ID band, then scans the vial, the system verifies that the two match the order, and the system cross-checks the scan against the active order in the EMR and blocks administration if there's a mismatch. BCMA prevents pre-mixing and administration errors by providing verification at the moment of care and by automatically documenting administration in the medical record. This isn't theoretical. BCMA is the gold standard for patient safety, and high-quality evidence supports BCMA's effectiveness. The Leapfrog Group, a nonprofit group tasked with recommending best practices, reports that BCMA is proven to reduce medication administration errors by 65 to 86%. They base this recommendation on numerous studies, all reporting significant reductions in medication administration errors and improved documentation after implementing barcode scanning systems. These studies, Truitt et al., Thompson et al., and Grayley et al. Specifically. Safety organizations such as the AHRQ recommend BCMA as a key technology to reduce wrong patient and wrong drug events when integrated with the workflow redesign and staff training. The following 3 studies alone collectively make a very strong case for BCMA, covering why, how, and the cost. Hohenberger on safety, Thompson et al., QI process and training, and the cost is analyzed by Sikowski and Ketchel, proving a return on investment. In a study by Sikowski and Ketchel in 2013, they concluded that from a hospital's perspective, implementing and operating BCMA is a sound financial strategy. The cost to prevent a harmful error, around $2,000, is significantly less than the lowest published estimate for the cost of treating a harmful error, which ranges from $3,100 to $7,400. BCMA is therefore an effective and potentially cost-saving tool that improves patient safety while providing a favorable return on investment for our community hospitals and clinics such as ours. Potential barriers include upfront cost, barcode labeling for compounded serums, workflow disruption, and staff resistance. We will mitigate these by limiting initial scope to a pilot, negotiating vendor terms and using pharmacy-applied standard labeling, engaging staff early in the workflow design, and using super users and competency checks to prevent workarounds. Resistance often comes from staff claiming BCMA takes too long. However, Epic research found that using mobile scanning devices like a rover on a tablet resulted in higher compliance rates of up to 11.7 percentage points higher in fast-paced environments. This is by a study by Epic Research in 2024. Therefore, I recommend we implement mobile BCMA for our practice to keep the scanner right at the patient's bedside. The alternative is potentially serious or even fatal patient harm. This is simply unacceptable, and the potential cost of just one serious adverse drug event far outweighs the cost of this technology. We will track the percentage of injections scanned at the bedside, the number of barcode intercepts, any wrong patient serum events, near misses, and balancing measures such as time per injection and staff satisfaction. A practical target for pilot is achieving a greater than 95% scanning compliance by a 3-month interval, and demonstrating intercepted mismatches that would have resulted. I request leadership approval to start the pilot, authorize a kickoff meeting, appoint a stakeholder lead, and allocate minimal funding for scanners, labels, and training. Implementing BCMA for injectable allergy serums will strengthen our safety defenses, reduce potential harms and risks to the patients, align our clinics with national best practices. So thank you very much for your time. I welcome any of your questions, and I'm prepared to present a detailed budget and timeline at the kickoff. These are my references. If you'd like more references, I'm totally prepared to do that. And I hope you have a good day, and thank you very much.